Yes.
So you will again result in misinterpretation. So you go to elevocranial, as Dr. Sharad said, then compare guide size with the LCX size. Go to elevocranial.
So wherever you want to compare size of the guide to your vessel,
Yes.
in that particular view, both should be on one side of image intensifier. I mean, that's the crux of the matter. If one is very close to image intensifier and other is far away, then you will misinterpret.
Okay, sir. Sir, and one more question, sir. When we were mentioning about the angle between the LAD and the LCX,
Yes.
it was described in the study was described in RAO caudal. If
Yes.
it's less than 50, chances of plaque shift is high.
Yes.
Sir, but usually we, in practice, what I have seen is we usually see the angle in LAO caudal, not in RAO caudals. LAO caudal gives the spider view and is it better. That's what was discussed.
Yeah, but the study which discussed this point, that study discussed only RAO.
Okay.
So far, I have not seen a study, which discussed this angle in LAO caudal view.
Okay, sir. Okay.
Yeah.
So
one more point is that in elevocaudal, there will always be some overlap of LAD segment on the LCX. So that makes angle interpretation difficult. Of course, sometimes we go to extreme caudal, extreme LAO and try to see it, but there is always some component of overlap of LAD on the LCX that results in misinterpretation of angle.
Yes.
Okay, sir.
I mean, those are the reasons why they selected RAO caudal view.
Okay, sir.
So that's why always, whenever you see a distal LM bifurcation lesion, either hostile LAD, hostile LCX, distal LM lesion, don't end your angiogram without
caudal.
Yes. I think that's a message.
Yeah.
But still, this RAO caudal view and a lesion beyond 60 degrees, most often it rules out a block shift, but it is not 100%. Please remember, it's not 100%. Still, block shift is possible.
Okay. Yes, sir. Thank you, sir. Thank you very much.
Yeah. Other participants, any questions? Yeah.
Hello, sir.
Yeah.
Hello, sir. Dr. Subramaniam, sir.
Hey, Subbu.
Sir. Hi, sir.
Hi, boss.
Sir, I got a doubt, sir, regarding the angle, whether it helps in selecting the guide, sir, either the EBU or JL.
Which angle?
Sir? The distal LAD L6 angle. And the left main size, length of left main, regarding selection of guides, sir.
Guide based on angle won't decide guide.
Okay, well, length of left main only.
But if you have a very steep LCX, right?
Sir,
the angle is very high. And if you are doing an LCX angioplasty,
yes, sir,
then you need a good support catheter. Gel doesn't work.
Yes, sir.
When the angle is too steep. Right?
Okay.
So when LCX angle is too high, I mean it is towards 90 degrees, it's always better you take a support catheter.
Okay.
But general saying is that for LCX lesions, EBU is preferable.
Yes.
And LAD lesions, XB is preferable.
Okay.
It is a general.
Okay, both are different company names, no? So both are of same.
No. Sridhar.
No. Yeah.
Sridhar.
Yeah.
See, for left system,
right.
For LAD, most atraumatic guide is JL.
Yes.
Okay.
JL works for even a routine LAD.
Okay.
But for LCX, JL is not a good catheter. For LCX, see, JL always faces towards LAD.
Okay.
It won't face, LCX. So, but for LCX, your EBU or XP works better.
Okay.
Because it is neutral in position and most often it faces even LCX also.
Okay.
right? And
My
more
point
importantly, LCX needs more support than LED, because LED is a relatively straight, vessel.
Yes, sir.
That's why that EBU shape is a bit better for LCX angioplasties. Is there anything you want to add?
structurally, there is little difference between EBU and XB. So there are, though they are extra support catheters, there is some difference. What do you say, Dr. Karan?
Yeah. There is a difference.
There is a difference. That's the reason why general tendency is to say is
The
that
curve
for
is more smooth in EBU.
EBU, so
It is
that's
more acute.
more acute. That's the reason why it faces LED more.
Yes.
XB. So that's
Yes.
the reason why sending wire, steering wire, it becomes easy for LCX, LED.
Yeah, that's
LED.
true. That's true. Yeah.
Okay, sir. Okay. Thank you.
Short LM. Again, in short LMs, I mean, Kalyan is asking one question. Short LM, in short LMs, again, it is better, see, JL is a better choice, because if you put XB, it enters into one of the artery. If it enters into your target artery, it's fine. If it enters the other artery, then it becomes tough. You have to put a wire into that artery, pull the guide out, then send second wire into the other artery. So JL works a bit better, because it just stays at ostium. You can steer your wire into wherever you want, because LM is very short. And yeah, see, another point the technique which I use most of the times, because of short LM, sometimes when you are doing angiogram, your catheter goes into, most often I feel it goes into LCX during angiogram. Most often it goes into LCX. That is my experience. So how to selectively engage LED? See, in those situations, you can take LCX angiogram separately with couple of views, right? Then again, you have to take LED angiogram separately. See, if you try to inject when catheter is in LCX, and if you try to visualize your LED, streaming will come into picture. So when streaming comes, you will always overestimate your lesions. So that's why it is better to take a selective angiogram of LED as well as LCX. So the technique which I use, see, most often catheter goes into LCX with a new catheter. You take your LCX shots, then go to elevocaudal. So in elevocaudal, you can clearly differentiate, LCX and LED. And in elevocaudal, you try to rotate your catheter clockwise and push it in. Just pull it back. That is, it comes out of LCX. Rotate clockwise and push inside. Right? Then it enters LED. So you try this in elevocaudal, most often you will be successful. I mean, this is not described anywhere. So this is my experience.
And another this thing is, another method would be just disengage it, go to the sinus, take it, loop it. Generally, by taking a loop, the catheter obviously faces slightly toward the LED side. So generally, you can engage. If you really can't engage, just go to RAO and take a non-selective shot, wherein your relation of tip of the catheter with the ostium of LM will be visible. So you can make some small movements, either clockwise or anti-clockwise, and just engage that. So because the tip is facing up, it just selectively engages LED.
So sometimes even in long LMs, so when you try to wire LED, most often wire goes into LCX, very often. So very often your wire goes into LCX. To turn your wire into LED, the same technique can be used as told by Sridhar. You push once your guide is inside LMCA, push it down. If you push it down, it faces towards LED. So once push it down and then send your wire. Instead of bending your wire, you can push your catheter down and you can go into LED with the same wire. Otherwise, you will tend to bend your wire. If you bend your wire too much, after entering LED, it becomes difficult. It will try to enter into all the branches. So this is one technique which we can use. Yeah, any more questions?
I think sometimes when you have a distorted aorta, frequently we encounter the tiger not getting engaged into the left main. In a distorted aorta, it either faces anteriorly or posteriorly. So sometimes by taking a deep inspiration, sometimes you will be able to engage it. But most of times it does not. In such situations, same step, like push the catheter into the sinus, take a loop, come to RAO and give a non-selective injections. In RAO view, again it is an enphased view for the LAD ostium also. You will exactly know where the LAD or LM ostium is, and you know where your tip of the catheter is. So you can make movement either clockwise or anti-clockwise just to engage it into the ostium. This, I think this was the step which was told by Sharath many years back. I keep on doing these things. So most of the times you can save time, contrast, and this thing by doing these maneuvers. Most
and
of the time,
catheters. You can reduce your number of catheter uses
also. So frequently, it's not a boasting, but generally I don't try to shift to other JLs or ALs. Most of the times, 99% of times, I try to finish off the angio with Tiger itself by doing these certain maneuvers.
Yeah. Any further questions? Yeah. If no questions, yeah. If all of you, if you would like to see a couple of cases, I'll just go through those angiograms. Shall I show?
Yes, sir. You can.
Yeah. And share my screen now. Claim hoster.
Which this thing?
Ide. నా స్క్రీన్ షేర్ చేయి అయిపోయిందా స్క్రీన్ షేర్డా ఓకే సో యా Sridhar, are you able to see?
Yes, I am able to.
Yeah, right. See, yeah, I'll just show forgot. So where is the angio? Oh, I think I missed this guy. Yeah, okay. This is one case. So a patient now had angina, post-bypass patient. He had a stable angina pectoris with decreasing functional capacity. Angiogram was done and identified as a lesion in right coronary artery and proximal lesion, osteoproximal lesion. And they did angioplasty. But 6 months later, again, after angioplasty also, patient had a persistent symptoms. And 6 months later, again, he came back with same symptoms which he had during initial angioplasty. I'll show you the angiogram. You just tell me. The point here is we need to comment on the significance of osteal lesion in RCA, number one. Number two, whether the stent is covering ostium or not. Am I clear?
Yes.
Yeah, so I'll show now. Are you able to see?
Yes.
Yeah, I'll play now. See that you can give a commentary.
Yeah, it looks
Your
like
side.
it's LAO view.
Yeah.
I think
How is your ostium coverage in LAO view?
stent coverage.
Yeah, stunt coverage. Stunt is covering ostium or not? In LAO. It
Appears
appears
as if
it is covering.
it is not covering.
No. I mean, basically it is very difficult to tell in this view. But by and large, for me, it is appearing, it is covering.
Okay.
Are you able to see any lesion there?
Not really. There is a good reflex
Yes.
also.
Yeah. So there is no lesion at all, right? And it
Right.
appears stunt is covering the lesion,
Right.
and there is it appears stunt is covering the ostium, and we are not able to see any lesion there, right?
Right. Right.
Okay. So that's a conclusion with this view. Right. So I'll go to other views. But the only problem in that LAO view is if you see your catheter, yeah, I'll just show you again that view. See your catheter is, see this is the view which we have. Your catheter, is it facing towards right or is it facing anteriorly?
Anterior.
Right? Your catheter is facing anteriorly. We can clearly say this is a RCA coming from anterior aspect of sinus. So when it comes from anterior aspect of sinus, in your typical LAO view, it is very difficult to see the ostium of RCA. Please remember. So you can't see ostium of RCA in this view, right? But if your catheter is completely to the right, then you can see your ostium of RCA. So probably that's a problem which happened during angioplasty. Now I'll go to the other views. You can see this is the other view. I think it's LAO caudal view.
Right.
See that you can give your comment about ostium as well as covering of ostium by the stunt.
Right. Now it appears clear that stent hasn't covered ostium and there is a significant block. So at the ostium.
Yes.
Right.
I
And
think this is a lateral view.
Yeah.
Sorry, this is lateral view. Okay. So, but that patient, the stunting was done in a LAO view. I'll show you more views. I think epicranial. Yes. Sridhar, you can see now.
Yeah.
You can comment.
Right. So I think stent hasn't covered and there is a significant osteoproximal lesion.
Yeah, see, that's what exactly happened. See, in this case, because it is an anterior RCA, whenever you are doing angioplasty in such a case, the view is very, very important while covering ostium. If you do this case in LAO view, that is the conventional view where you do angioplasty, you will tend to miss ostium. So patient will come back to you. That is what exactly happened. So we missed ostium because the angioplasty is done in a LAO view and your stunt positioning is done in a LAO view. Ostium is missed. So that's the reason. So patient came back with a stenosis. I mean, the existing stenosis which was already there caused further symptoms. So it is incomplete coverage of ostium. This is what exactly happens. This in ioto-osteal lesions, like either RCA or left main coronary artery. So, and in this case, yeah, I have done FFR. I mean, because there was a difference of opinion from cardiologist in my place. So I have done FFR. So FFR was significant for this patient, and it's less than 0.70. You can see here. And after FFR, I did IVUS also. Unfortunately, I couldn't play IVUS to you. IVUS clearly showed stunt is ending 4 millimeter beyond the ostium. So ostium is not covered at all. And the minimum lumen area of the ostium is, I think, around 1.9 millimeter square. So this clearly says we missed ostium in first stunting, right? That is a longitudinal geographical miss. See, geographical miss is the most important factor for restenosis at stunt edges. So that's why patient came back with a restenosis. It's not a restenosis, it's a lesion which is missed. That's the reason his symptoms also persistent. So we did an IVS guided stunting for this guy and he is asymptomatic. Almost we have done 1 year back. First time, within 6 months of angioplasty, he came back. Angioplasty is done elsewhere. Within 6 months of angioplasty, he came back with symptoms. Now, we did an IVS guided angioplasty. And another point which I want to make, IVS is a very, very good investigation to locate your osteum. So in angiogram, you may not be able to locate, but in IVS, you can locate. See, when you are pulling your IVS catheter back, wherever osteum comes, you stop there and go to different views. Take a small check shots. So then that is the osteum. So, and you take a view where your osteum is well separated from the sinus or clear to you. In that, you go to that view and take a picture of your IVS catheter location and keep it in your reference frame, and then take your stand and position exactly with your reference frame, and you just deploy it. So IVS helps you a lot in locating osteum in these kind of ambiguous osteums.
I think
now you understood why the art of angiography is important, in treating patient.
I think this is a clear-cut case of foreshortening and overlap because it is not a normal origin RCA.
Okay, so I'll try to go to another case. Yeah, this case, I'll show complete angiogram. Are you able to see?
Yeah. Yes.
Yeah. I don't have, angiographic pictures. I have pictures of, procedure.
Sir?
See, I'm giving dual injection in this case.
LED osteum.
Yeah, I'm giving dual injection from RCA as well as LAD.
There is a total occlusion of LAD.
Yes.
From the
And
osteum.
also LCX.
Yeah.
Distal LCX. And also distal LCX.
Right.
And what I want, see, how is a distal LAD? And his RCA is normal. LCX is total occlusion. LAD is total occlusion. What do you do this with this patient? Do you want to send this patient directly to EAPG? Or do you want to do something else?
So it's basically underfilled vessel.
Yes.
We don't know whether it is underfilled vessel or it is a diffuse disease.
Yes. Say it is, it is diffusely diseased. What do you do? Would you love to send this patient to bypass surgeon?
No.
See, that is what exactly we have to do. Many times what we do, see, the moment you see this kind of picture, we'll try to send patient to surgeon. We'll dump, literally, we dump patient on surgeon. But these cases are not ideal, for grafting. May not be ideal. So when the vessel is so small, right, and not filling completely, you can see it is looking like there is a diffuse disease distally. In fact, in this case, we have done CT angio. So, and we did virtual IVS in CT angio, and which showed a diffuse disease in the vessel. So, and I had a discussion with surgeon. So, how best he can give a graft to this LAD. Surgeon was really not interested in grafting this LAD. So, that's how it will be, right? In such a case, see, in an angiogram, in a total occlusion, beyond total occlusion, if your vessel is not visible in any view, always you have to try to see your distal vessel before taking a final revascularization decision. Please don't send or don't take a revascularization decision without visualizing distal vessel. That is my message which I want to give. So, and I'll show you what we have done. See, we did, in fact, it is a blunt, ostial flush occlusion of LAD. See, we used IVUS guided entry into LAD and we entered, and then we opened LAD. I'll just show the LAD, how LAD was after opening. So this is after IVUS guided entry and the dilatation. Can you see the LAD? See, till the diagonal, I have dilated the vessel. See the vessel below the diagonal. How is it?
Diffusely diseased.
It's diffusely diseased. And we did an IVUS. IVUS clearly showed blocking everywhere. And these are the cases where you can use IVUS to, decide where you can end your stunting. So clearly there is a diffuse disease and clearly there is a negative remodeling of the vessel. So, I mean, this is not a right case. See, if you send this patient to a simple, if you send patient to bypass, yeah, nothing may happen, but this bypass graft to LAD may not work. So that is the issue. So never take a revascularization decision without visualizing vessel. You just see the vessel after stunting. So there is diffuse disease. We just stunted this vessel, and this patient is in follow-up since 2 years. Sorry, almost 4 years. He is doing fine. In fact, I advised a repeat angiogram just to understand, how the distal vessel is behaving. You can see the distal vessel now. All diffusely diseased. In such a disease, in my experience, surgeon has to do, endarterectomy and do a grafting. So something like de-roofing, all that stuff. And in my personal experience, I have seen good number of grafts getting closed within 48 hours of endarterectomy. So, make sure your distal vessel before sending patient to surgeon. If you can't see in your angiogram, please take the help of a CT angiogram. But before jumping into CT angiograms, say for example, it is an LAD total occlusion. Always you have to take long cine angiograms into your right injection, into your right coronary artery, right? It is the RCA total occlusion. Take long injections into your through your left coronary system. So that is how you can differentiate. Despite long injections, despite long cine, if you can't see, then take the help of CT angiogram. And if CT is also not showing anything, then it's like a borderline case. You have to really discuss that case with surgeon, before ending up in a revascularization. So like this case. Any questions on this case? Yeah, any questions?
Sir, what is the best view for LAD ostium, sir? Ostium stunting.
What is the?
LAD ostial stunting, sir. Best view.
Oh, best view. So there is nothing like a best view which works for all patients, right? So you have to choose a view for your patient. So most often, either it is aleocaudal or epicaudal.
Okay. Thank you, sir.
And sometimes it could be even areocaudal. So you have to tailor your view to your patient. And at times I find difficulty in finding a view. So then what I do is I'll take a rotational angiogram. So commonly what I do, I'll come from aleocaudal to epicaudal by, you just rotate and see where your stunt is. So